So today I've been dispatched to Bob here. Bob is a 70-year-old male with a chief complaint of chest pain. So Bob's had an acute onset of chest pain today and palpitations. States that it feels like his heart is pounding out of his chest. He's also been unable to walk around as he feels like he's quite dizzy and going to pass out. So I've just popped him in a supine position here. Bob's medical history: Bob did have an MI about 5 years ago, but states this pain does feel quite a bit different. Medications: Bob's currently taking Cilazapril and aspirin. So today, just starting to assess Bob, I've done a quick primary survey. So his airway is patent and clear. His breathing, he does have a slight increase in work of breathing. His rest rate's sitting around 24. Auscultating his lungs, he does have bilateral crackles, and his SATs were sitting at around 88%. So we've put him on high flow oxygen at 8 litres per minute through a non-rebreather mask, and that has brought his SATs up to about 94%. Circulation, so Bob is quite pale and clammy. He has absent radial pulses. His carotid pulse is quite tachy, but it is regular and strong. He also has a prolonged peripheral capillary refill time of around 4 seconds. And his vitals, so his vital signs: he's got a heart rate of 170, a blood pressure of 70/40, a rest rate of 24, a BGR of 7.6. His temperature is 37, and his initial GCS is 13, made up of 3, 4, and 6. So I then went ahead and did a 3-lead on Bob here and printed off a strip. It's looking like Bob is in VT at a rate of about 170 beats per minute. So I then went ahead and attached the defib pads and called for backup for an R50 for status 1 conscious VT. Just to be sure, we do want to rule out a couple differentials first. The most important one being SVT with aberrancy, as that can mimic VT. So some signs that point us more towards VT than SVT. So the patient's of an older age, and they've had a history of a myocardial infarction in the past, and they've got some cardiac medical history such as ischemic heart disease, congestive heart failure, or left ventricular dysfunction. So Bob is of an older age and has had a previous MI in the past. Some signs on the ECG itself, and we're looking for AV dissociation, right axis deviation, or the presence of capture or fusion beats. We could do a 12-lead and look for precordial concordance. Bob also has a normal BGR and temperature, so we're not thinking sort of sepsis-induced SVT with aberrancy. But our sort of big differentiator is Bob's level of compromise. So patients in SVT with aberrancy are less likely to be severely compromised than patients in VT. So to determine if a patient is severely compromised, we're looking for markedly abnormal vital signs. So Bob is extremely hypotensive, he's pale and clammy, he has no radial pulses, and he has a prolonged capillary refill time, so he's kind of got all those signs of poor perfusion. He looks status 1, so he's at a high risk of cardiac arrest, but our big differentiator is whether Bob is able to obey commands. So Bob, can you squeeze my hand for me? So Bob's now unable to obey commands, so that does put him in the severe compromise category. So now that we've gone through a good sort of list of differentials, and we are fairly certain that this is indeed ventricular tachycardia, we are going to start heading down the cardioversion route. So I've gone ahead and we've got our defib pads attached, got all our diagnostic gear attached as well. I've gone ahead and gained bilateral IV access. We're already giving high flow oxygen, and I've got our resuscitation gear out and ready just to be prepared. If our patient was able to obey commands, we would need to go down the sedation route using ketamine. So that would either be given by an R50, or we could call clinical desk and administer under their supervision, and we would be giving 0.5 milligrams per kg. But because Bob isn't able to obey commands, that step isn't necessary. So the next thing we need to do is, I've got my cardioversion checklist handy here, and a friend just off to the side, and I'm just going to have her read out the steps, and I'm just going to check everything is in place just to make sure that the procedure is done correctly.
Cool. Place pads in either the apex or sternum or anterior-posterior position in addition to ECG electrodes.
Cool, so we've got our defib pads attached here, and we've also got our 3-lead attached, and we could go ahead and also put on a 12-lead as well.
Ensure the defibrillator is in manual mode.
So our defibrillator here has been turned around to manual mode.
Select a lead with a visible R wave and ensure that artifact is minimized.
Cool, so I can just cycle through our different leads here, just looking for whichever one has the most visible R waves. So lead 2 here is looking pretty good, and because we're not in a moving vehicle, there's no disturbance. Just looking at the monitor, we don't seem to be having any artifact.
Select synchronized mode.
So just push synchronized mode in the corner here. Cool.
Confirm there is a detection symbol above every QRS complex.
So I'll just go ahead and print out a strip just to be sure. And then we're just looking at the little dashes above our R waves and confirming that there is indeed one above every QRS complex. Yep, so we've got that.
Ensure the patient has received adequate sedation if indicated.
So I'm just going to check that Bob is still unable to obey commands. Bob, are you able to squeeze my hand? So Bob's still unable to obey commands, so he's at the adequate level of sedation.
Select the joules and charge the defibrillator and confirm everyone is clear.
Cool, so there's no one around my patient. We've selected joules all the way to max joules, and we're going to push charge. Cool.
Press and hold the shock button until the shock is delivered.
Okay, so everyone clear, shocking. Cool, so shock delivered.
Determine the rhythm and the level of cardiovascular compromise.
So we just print out a strip again. We can recheck the rhythm. So it does appear that Bob has reverted into a sinus rhythm, and then we would go ahead and check his level of cardiovascular compromise. So like I said before, we need to take another full set of vitals, check his blood pressure, heart rate, capillary refill time, and all that again just to determine what his level of cardiovascular compromise is at the moment. If we were administering a second cardioversion, if he didn't revert back into a perfusing rhythm, we'd just go through the exact same process again. We would still recheck his ABCs, his vitals, and just ensure that we do push sync again to make sure that the defib is still in synchronized mode.